excited to see you too. I'm
All right,
excited to talk about the book.
Yes. All right. So this is it for everybody who is joining. There is a pinned, if you would do nothing else in this Instagram live, in this video, you should get Gillian's book. There is a pinned comment. It has a beautiful cover. We'll send you a link via DM. So before you listen, just go get the book. But let's start. Let's convince them, Gillian.
Okay.
So let's start by just having you introduce yourself. Tell us who you are, what your book is about, and why you love hormones so very much.
I'm Dr. Gillian Goddard. I'm an endocrinologist and professor of medicine at NYU Grossman School of Medicine. And I am the author of the newsletter, The Savvy Patient, and this new book, The Hormone Loop.
I love it. So I met you. So I'm Emily Oster. I'm a professor of economics and a writer of books about parenting and pregnancy. And I met you because you did a bunch of writing for my Parent Data newsletter about hormones and perimenopause. And I will say, I just want people to know, like, I love Gillian so much, and I trust you so much with these questions. And I am just very grateful personally for both this book and for you as a friend who will tell me all the things, like tell me the truth about all the things that are going wrong with me. So maybe later in the discussion, we can get into some concerns I have.
Absolutely. Recently. No problem.
But I want to start, actually, there's a comment already in the chat from Gina that says, is this book more for younger or older people? I actually think that's like the perfect place to start this discussion, because there is so much talk now about menopause and perimenopause. And what is so useful about this book, and I think about your frame, is the view that this is not, hormones are not a thing that arrive when you are 46 and have never been there before. So give us a little bit of the picture of why hormones are something we should always be talking about.
Yeah, absolutely. I think, we tend to talk about hormones at these very discrete times: puberty, pregnancy, perimenopause, and menopause. But they are there all the time. They are always working, and they are actually always affecting our bodies and how we experience the world from before puberty, but we really experience them in their full iterations, from puberty all the way through the end of our lives. And so I think it's really important to realize that they're there all the time, and they're not these discrete stages. Each stage kind of gently undulates into the next, but sometimes less gently. But
is that okay?
Some stages are more dramatic than others, but really in this book, we talk about how your hormones change across your entire reproductive life and beyond.
So why do you call it the hormone loop? So what is the loop?
Sure. So all of our hormones, well, not all, many of our hormones, the main hormones that we think about, exist in these feedback loops. And I think sometimes this is a little difficult for people to conceptualize. So I think a great way to think about it is picture two people playing ping pong. Probably not you and me. I'm really bad at ping pong.
Not me.
Picture two good people playing ping pong.
Okay.
And they're hitting the ball back and forth. And every time they hit the ball a little differently. They adjust where they're standing. They hit the ball at a slightly different angle, so that they can keep the ball in play. So the ball keeps going back and forth and back and forth. And now imagine that the players are your glands and the ball is your hormones. And what's happening is your glands are keeping this conversation going by sending the ball a message back and forth to one another, but they're doing it slightly differently every time so that the ball is constantly in play. That is what our hormones are doing behind the scenes all the time.
And so you talk about the sort of undulating of the hormones, and the book is really sort of structured around how hormones vary over the life cycle. I think, of course, in some sense, you are exactly right that there are. You must be right. You're an endocrinologist. By the way, I should tell people there are almost no like getting to talk to an endocrinologist is like a treat because there's almost none.
Yeah, there's 9,000 of us like in the entire country.
Yeah. So so there's the undulation, but there are also these more discrete time periods you sort of talk through in the book. And one of the things I actually think is very nice for many of the potential readers of the book is that in our lives, the period in which we are going through one of the larger hormonal transitions, perimenopause, is often the same as when our daughters are going through another one of those transitions, which is called puberty, and our sons. And so there's a sort of natural undulation of this. But do you want to give like a little bit of a picture how you'd sort of see like what are the big sort of at least periods, if not moments?
Yeah. So I think the big moments you've touched on too, puberty for sure. Everyone goes through puberty. Many of us probably remember with some horror going through puberty. Great time in life. And then there's the peak reproductive years. We don't always think of a lot going on in these years, but these are also the years in which many of us decide to get pregnant and have babies. And so we experience pregnancy, which is its own hormonal experience. And then perimenopause, which you and I are in. And then menopause.
Speak for yourself, Gillian. Speak for yourself.
All right, I'm in perimenopause.
Yeah. Mm. Gillian and I are having too much fun, guys. Okay, so then there's perimenopause.
Perimenopause, and then there's menopause.
So what would you say? By the way, I will say people's questions in the chat here are awesome. Please keep putting them in, and I'm going to pepper them in for Gillian because they're very good. So what is the most important thing you want people to learn from the book?
I mean, I think the biggest takeaway when we think of hormones, we often think of the reproductive hormones. We think of estrogen, we think of progesterone, we think of periods. And while those things are very important and they are, and they're sort of the part of our hormone, our endocrine system that we experience the most, there's all these other really important hormones that are affecting how we feel. And the reproductive system is like the tip of the iceberg.
So we think, when we talk about hormones, I've got in my head progesterone and estrogen, but in fact, the hormonal system is quite a lot more fancy.
Yeah, very fancy. And if we don't know that, we don't necessarily know what questions to ask or how to talk to our doctor about what we might be experiencing.
Yeah, so I think that's for when I think about so this book has kind of both a like I am interested in learning piece, but then there's a very practical piece here. And I think the two questions that I want to get a little bit more deeper into are questions that people have about like, I'm going to frame it wrong, but like optimizing hormonal health. And we can talk about that means, and then the question about sort of how to talk to my doctor about these things. So let's start with the first one. So if someone and they say, I'm concerned about endocrine disruptors, which is a whole other topic. Like, I want to optimize. Like, is there a sense? Sorry, let me just ask it the basic. Like, should I be optimizing my health in hormonal health? Like, and in what way?
If you're healthy and things are humming along nicely, you don't have to do anything to optimize your hormonal health. Your hormones do it for you. They are self-optimizing.
And how would I know if they were going?
You would absolutely feel it. You would have symptoms. Those symptoms might be period-related symptoms. They might be mood-related symptoms, energy-related symptoms. But you would have, if you're not having symptoms, your hormonal system is humming along.
I think people find that very hard to accept. I think in our
I
current,
know.
like, in our current moment, it's sort of like, okay, you're saying it's working, but like, it could be better. Could it be better? And I think this, I mean, in some sense, it comes up more, I think, with men. I was
Yeah.
just reading about testosterone. Men are always into having
Oh,
more testosterone.
they're very into having more testosterone.
Very into it. But I do think the idea of just like, well, if you're not feeling bad, everything is fine. Like,
I know.
but isn't there a supplement? What about adaptogens? Is that important?
No. I mean, no, if you are feeling good and your hormones are humming along, you are doing okay. So what you really want to do is arm yourself for those times when you won't be feeling okay, and to have the information that you need to kind of think through, well, now I'm not feeling okay. What do I do about that? What questions do I need to ask? How do I think about my symptoms? I mean, I think that's where we can really prepare ourselves in advance, especially because we know that, more than 80% of women will have symptoms going through perimenopause into menopause. For example, anyone who's lived with a teenager knows that their teenager is having symptoms of puberty. And so I think we can prepare ourselves. And I think this is a concept. So my pediatrics colleagues do this really, really well. They're taught to do something called anticipatory guidance. So when you go in for your kids' 6-month visit, they will say, these are the things that are going to happen to you to your baby in the next 6 months. And so it's sort of like, don't freak out if this happens. You can expect maybe this will happen. Adult doctors are not taught to do that, and we're not very good at it. But people still want to know what's coming down the pike, whether doctors are good at giving that anticipatory guidance or not. The hormone loop is your anticipatory guidance for your hormonal system, soup to nuts.
Okay, before I ask my next question, I want to tell people on Instagram, if you want to get a link to get a signed copy of Gillian's book, comment shop, and then we will send you a link. Okay. So let's talk about this anticipatory guidance piece, because I think part of there's two really interesting decisions around how do I talk to my doctor, reach out to my doctor, think about what I need from my doctor about this.
Yep.
One is the question, and someone asked this in the chat, I think it's a really good question,
Mm-hmm.
which is just how would I know if I was feeling bad? And part of that is that it sort of decays. And how do I separate, that was a bad night's sleep, my job is really stressful, maybe my cortisol, something else is going on from there's something I need to do. So do you have some concrete, how would I know things are such that I need to reach out to someone?
I think there's a couple ways that you can know. I think during much of our reproductive lives, our periods are a great signal, a great sign. If your periods are regular, that's a sign that something might be going awry. And then when you then think about it, you can then be like, oh, well, I am more tired. I am having more headaches. I also think to some degree, these symptoms, they're out of the ordinary and you can't really explain them away. So for example, when I was about 43 years old, I woke up one day with a horrible headache. It woke me up in the middle of the night. And I thought back through my day, the day before. I hadn't had anything to drink. I didn't eat anything weird. I was feeling fine. Why did I have this terrible headache? Eventually I sort of blew it off, but then the next month it happened again. And then the next month it happened again. And so I think symptoms we need to pay attention to are often persistent. They don't happen once or twice. They happen more frequently. And sometimes they start to happen with a pattern.
And then we potentially link them to our hormones, which are looping around, particularly for women, on some kind of cycle.
Exactly.
What about the sort of general decay? But I mean, there's a sort of...
Yeah. What's the difference between aging and shifting?
Yeah, what's the difference? Exactly. I can, and I think for many people, we are now people, everybody's got an Oura ring, they got a Whoop,
Yeah.
they got an Apple
Yeah.
Watch, my Apple Watch tells me my HRV is in the trash. Like,
Yeah.
how do I
Yeah.
separate that from this, like, something is going wrong?
Yeah, I mean, I do think that this is a little bit of an unanswered question in the literature. We don't always know how to tease these things apart. But I think in general, the aging, the decay is a gradual process, and hormonal changes or something going wrong tends to be a little more abrupt.
Okay. All right. So imagine I've had an abrupt, something is happening that seems like it feels off.
Mm-hmm.
And I'm going to go to my doctor. First question. I go to my primary care doctor. I can't find an endocrinologist, presumably.
Yeah, presumably you can't get into an endocrinologist without a referral, and then you'll probably wait 6 months or even a year. So that's not an option for this, right?
I'm going to my regular doctor.
Yep.
And then how am I, and I think this is a part of the book that's really important, like, how am I coming into the 12 minutes that I have with my doctor to ask the right questions?
Yeah, absolutely. It takes a little bit of preparation. You don't want to go in cold, because your doctor, by the time you get around to your questions, your doctor will be out the door already. So I always tell people to start by thinking about a goal for your visit. And what I mean by that is not, I want a prescription for X. What I mean by that is, when I'm done with this conversation with the doctor, I will have a plan for figuring out why I'm having headaches. I will have a plan for managing my headache symptoms when they happen. So not something super specific, but sort of concrete. And so that's the first step. The second step is to gather some data. Yeah, you and I love data.
Love it.
It's like,
love it.
It's magic stuff. But you're actually gathering some data on yourself. So gathering some information about your symptoms. When do they happen? What exactly are they? Is there one symptom or a cluster of symptoms?
Do you have an app that you like?
I think whatever app you're going to use works best. My favorite app is pen and paper.
Okay,
and that's
ladies.
because I'm old. But most of
You're the dream.
Most of my patients use like the Notes app on their phone, which is perfectly fine, because you will have your phone with you in your appointment with your doctor. You will not forget it like you will forget a piece of paper.
Right.
And there will be almost certainly a little bit of lag time between when you have the symptoms and when you see the doctor. And so sit down, take some notes, really think through what you've been experiencing and try to distill it down. The doctor will want to know when it's happening, what exactly is happening, if anything has made it better or worse. And these are all data points that you can collect and have at hand when you talk to the doctor.
I love that. Okay. I want to ask a few of these questions from the chat, because I think one of the things that people are really would like to understand and think about is a range of symptoms that people can experience, particularly in this. And again, the book is not only about perimenopause and menopause, but there is a period. That period is much longer than many people.
That is correct.
Think.
Yeah.
We've talked about, you've talked on stuff that you've written about, the idea of the late reproductive stage, that you finish reproducing, but you aren't yet in perimenopause. And then we're talking about a 15-year period.
Yeah. So, yeah. Give or take.
Okay. So, my friend has been complaining about not feeling sexually attracted to her husband. Is this a potential hormonal problem? So,
yes, libido is hormonal, and there are a number of different hormones that can affect libido. Everyone will be shocked to hear that we know much less about what drives women's libido than we do about what drives men's libido. I know, Emily, that's shocking, isn't it?
The first time hearing it.
But we do think that testosterone may be involved in women too. thyroid can cause libido problems. I think the key question here is it you're just not interested in sex, or is it this specific person? Because if you're just not interested in sex, that could very well be a hormonal problem. You're not interested in this specific person is much less likely to be hormonal, because it's more situational. But you know, when we've been married for a long time, we don't often think about whether we're attracted to other people, or we haven't explored that idea.
Yeah, it's such an interesting, it would not have occurred to me to think about that, but of course it's right. Like, you know, there you're having trouble separating out, like, yeah, how to almost
Right.
like,
Do I need the
yeah.
therapist, or do I need the doctor?
Do I need the therapist, the open marriage, or the doctor?
Right.
Which is no. Okay. That's not this conversation. All right. So potentially libido as a potential. And is that something where, again, like everybody's treatment, everybody's experience with their doctor is going to be different, but like, is that something where in principle one could have, like, one could be there could be some improvement with some kind of treatment?
Yeah. So again, unfortunately, we don't know as much about women, but we do have a decent amount of data. There's a couple different options for treating libido. There's also can be issues around arousal that can be related to changes in vaginal dryness, or, you know, discomfort with sex, which can also be, let's be clear, like a turn off. If it's not going to feel good, kind of, why would you want to do it? It's sort of the point. And so I think that, yeah, there's lots of different options there, but you really do want to go in with sort of a clear picture of like what exactly you've been experiencing, because it'll help your doctor pick those details apart so that they're better able to help you.
The other question that people have on here is weight gain. So what is the relationship between these different hormones and weight?
This is an incredibly complex issue that we have barely scratched the surface on. But what we know is that as estrogen levels drop during the perimenopausal years, it allows us to put on weight around our midsection. So estrogen tells your body to store fat in your hips and thighs. And so when estrogen drops, it allows you to store more fat in your midsection. For many people, the ability to form fat in your midsection then affects your blood sugar metabolism and makes you insulin resistant. And as you're insulin resistant, you preferentially store more fat in your midsection, which makes you more insulin resistant, which makes you store more fat in your midsection. And so it becomes this vicious cycle.
It's a loop.
Indeed it is. At the same time, we do know that most women lose a small but really critical amount of muscle during the perimenopausal transition. It's actually only a kilogram, so only a couple of pounds of muscle, but muscle's so metabolically active that it really does make a difference. So when you lose this muscle, you actually burn fewer calories, both at rest and when you're exercising. And we don't know that's happening necessarily, and we don't necessarily adjust our behavior accordingly because we're not even aware of it.
Okay. So if people have other questions, put them in the chat. I have many questions. I actually want to go back. So again, what's sort of, this is not a book about perimenopause and menopause. This is a book about hormones.
Yes.
And we actually start at the beginning with puberty. And as a parent, I wondered about some of the same questions that you think about with perimenopause with our teenagers.
Yeah.
So, you know, teenagers, your teenage daughter has a period. They say my cramps are terrible.
Yeah.
Like, how am I supposed to think about what is a reasonable symptom and not a reasonable symptom in that early period? Because, you know, again, at some point I was reading about endometriosis. And of course, like a very large share of endometriosis cases are not detected until much later, even though they maybe could have been if people understood like this level of pain in your period is not typical.
Yeah. The average length of time to an endometriosis diagnosis is something like 10 or 12 years.
Yeah.
It's pretty insane. Um, I do think that this is a really difficult thing to parse out with a teenager, because I don't know about you. I will go home later. I will ask my daughter how she is. She will say she is tired.
Yeah.
It's mostly a way to shut down the conversation, probably. Like, mom, I'll talk to you when I'm ready to talk to you, and that time is not now. Um, but I think that if you've got a kid that's consistently complaining, it's hard for them to know. I mean, think about this. If you've never had a period before, how do you know what's normal? They hear all the time that periods are painful, periods suck, nobody wants them. Like, and so they don't know either. And so it's just as difficult for them as it is for you. But I think if it's disrupting their life, if they are having cramps that keep them from doing things like going to school, playing whatever sport they're into, doing the things they like doing, if they're not doing those things because they feel cruddy, like, it's definitely time to intervene. Or if they are like, they're so tired that they're like canceling plans with their friends. Like, every kid doesn't, maybe not every kid. Many kids don't want to get up early and go to school. Their hormones change their circadian rhythms, so they want to sleep all day and be up all night. But if they don't want to go do something fun after school with their friends because they're too tired, and that's something that's going on for days or even weeks, to me, that's a red flag. They should still be able to engage in the things they like to do.
In some ways, I assume the advice about interacting with a doctor about this is the same. You go to your pediatrician, but in advance, come with like,
Yep.
here are the patterns we're seeing. Here are some details. Here are some data
Yep.
about kind of why we have raised this to this
Yeah,
level.
absolutely. Because
And,
unfortunately, doctors and parents minimize teen and young women's complaints, particularly of pain. And so you really want to go in with some data to say, no, this is the situation. Advil's not helping. She's not playing sports. Like, you want to go in with some details to sort of support the case, as it
And I
were.
think this is a place where it's similarly to interactions with your provider on the other side. I think a lot of people worry, justifiably, that they are not going to be heard and listened to by their providers. And so somebody's put this question in, many primary care doctors will tell you everything's normal. That's
Mhm.
basically true. Like,
Yes.
it's sort of like, where the pediatrician, yeah, it sounds fine. It
Yeah.
sounds like not such a big deal. And I think people feel dismissed, and it's hard in that relationship to push back and say, like,
Mhm.
hey, like, you're like, this doesn't feel normal to me, as opposed to just being, well, I don't know, you're like a 45-year-old lady, yeah, sure, you're tired, like,
Yeah.
like, suck it up, or, I'm sorry, period's so painful, but like, whatever, welcome to womanhood. It's
Mhm.
just pretty much like this until you die. you know I wonder, how can people push without saying, to their doctor, like, you're doing a bad job, which
Yeah.
they're probably not, and also no one's ever going to say.
Right. I think there's a couple ways to push back thoughtfully. One is to go with the data and say, well, this is really a change. 6 months ago, I could do this, and now I'm doing this. Or, my daughter was, you know, playing sports every afternoon and coming home and going out with her friends and doing all these things. And now she's coming home and going to bed. I think pointing out that there's a market change is helpful. I also think getting curious about what's going on, and kind of, I think the best way to approach someone who's a little skeptical is with a little bit of curiosity. People often say, what do you do if your doctor doesn't seem up to date? Well, my question would be like, oh, have you heard about the X, Y, or Z trend in, I read this article about whatever. Did you see that? What are your thoughts about that? They might not always say yes, but what they should say is, oh, I haven't seen that, but I'll take a look and get back to you. We can't, I mean, reams of papers come out like on a daily basis at this point. And so no one can be 100% up to date. It's not possible, but they should show some interest and kind of engage with you if you approach it in this sort of curious type of way. Doctors are people. We have bad days sometimes. Your doctor will not be in a glorious mood every single time you see them, but it shouldn't be a pattern. It shouldn't feel like you're being dismissed every single time you go in. And if it does, then it's probably time to consider a new provider, or at least evaluate the relationship.
Yeah. And I think that actually is a important thing to put a pin in, like, you know, and many people are reluctant to quit their doctor the way they're reluctant to quit the gym. And of course, like, just because you have one, you know, people have bad days, like not every visit's going to be like the greatest experience of your life. But I think there's a frame on that, which is like this person could be a great doctor, but not for you.
I think people don't realize how important fit is when it comes to doctors, because some people want things explained in great detail. Some people just want you to tell them to take this and call me tomorrow. Like, different people want different things. And I think we don't always think about fit when it comes to doctors the way we do with some of the other providers that are out there, like therapists, for example. We think a lot about fit. And I think fit with doctors is super important. And I think good doctors know that. And if you're not the right, like, I would never be offended because someone felt like I wasn't the right fit for them.
Yeah, I think this is easier. You know, I talk to people about this in pediatrics a lot. And like pediatrics, like, you have an opportunity to pick your doctor at the beginning and like, what are the right questions?
Yeah.
But often we sort of happen into, you know, primary care for adults is actually pretty, like, can be quite hard to find.
Yeah.
You know, my husband's doctor is a doctor that specializes in women, because that's the only doctor he could find, and he has a woman's name, and so they thought he was a woman, and they like took him. But it's fine. I mean, she knows best. Anyway, my point is, it's hard to find.
It can be. This is why you should approach finding a primary care doctor the same way you approach a pediatrician. People go in months before they have babies and meet with pediatricians, and exactly
hours.
Exactly. And you should approach this the same way with a primary care doctor, by looking for a primary care doctor and trying to establish care before you're in this critical situation. Because then too, you have a relationship with them, and they know you, they get to know your personality a little bit. And so they then know, like, if you're complaining and you're not usually doing that, like, that's real.
Yeah. Okay. What is your least favorite online hormone hack your hormone fad? Pick one, the one you hate the most.
Oh gosh, the one I hate the most is probably, this is a hard question, Emily.
I know. There's so
many choices.
There's so many options. There are so many options. Maybe the easier,
many choices.
Will be,
I would say that you need to do something specific to manage your cortisol, like take like one of these like cortisol calming supplements.
Okay.
Yeah.
So I'm going to throw that away. So cortisol calming supplements, but somebody says, like, there's a lot of conflicting advice online. Agree.
Yes. 100%.
Like, beyond the sort of like, if you really have a problem, if you're having issues, see your doctor. Like, is any of this something I should be like, should I buy anything from the TikTok shop related to my endocrine system?
Almost nothing. And I say almost because if you are a woman over 50, you should probably be taking some calcium. And there is a growing literature on creatine for women in midlife.
But is the creatine literature and the calcium, is it about hormones, or is that about bone health, or is muscle health, or it's just everything's about hormones? So,
it's all about hormone. I mean, bones are hormone driven. And so
This is what it's like to talk to doctors. They're like, well, my thing is hormones, so everything's hormones.
To a hammer, everything is a nail.
Exactly. Okay, so a little bit of calcium and creatine, but I don't need any adaptogens,
No
dysbiotic,
adaptogens.
abiotic,
No.
no functional medicine of any
Nope.
nature.
Nope.
And let me ask one more symptom question before we kind of wrap it up, because I think people's attention span for this is 45. All my attention spans are 45 minutes.
Yep.
But I think the biggest, like, difficult to interpret symptom is exhaustion.
Yes.
So people are tired.
Yeah.
You're tired when you have little kids, and then you're tired, and then you're tired. And I don't know how anyone could tell the difference between, like, what's the self-experimentation? Is it like, try to sleep better for a week? Is it like, what is it that tells me my tired is something that is my hormones as opposed to just other things?
Yeah. I mean, I think there's two questions. I think the first question I ask people when they come in and say that they're tired is, are you sleeping? Because if you're not sleeping for whatever reason, you will be tired. Adults need 7 to 9 hours of sleep on average per day. And if you're not sort of meeting your sleep needs, you will be tired. Now, that doesn't mean there's not something wrong. The question then becomes, if you're not sleeping, why are you not sleeping? Right. So we all know, like, if you have a newborn at home and the newborn is waking up and you have to get up and feed them, you will be tired. People expect that. If your hormones are waking you up in the middle of the night, you're having night sweats, and it's waking you up and you have to get up and get the towel and, go to the bathroom. And if you're doing that 4 or 5 times a night, you will be tired. The way that you would manage those two different disrupted sleep situations are totally different. One will get better with time, and the other one, maybe we need some hormone therapy, for example. So if you're not sleeping, we should be troubleshooting the not sleeping. If you're sleeping and you're still waking up tired, and this doesn't mean one night, this means, like, you get a great week of sleep, you go on vacation and you sleep on vacation and you're sleeping uninterrupted, maybe your kids aren't there and you're still tired, that's a different issue. And that's potentially, all these other things where you maybe need some blood work and a workup to figure out, like, is your sleep not good? Is it, are there hormones that need to be adjusted? And so I think the first decision is, are you sleeping or not? And if not, why?
Yeah. And I would have guessed, based on what you see, that most people who come in who are very tired are not sleeping for some reason. And the reason could be hormonal.
Yeah. Yes. The reason is often hormonal, but yes, oftentimes when I see people, they're not sleeping. Although there are some hormonal things that you can be sleeping and still be tired. Hypothyroidism would be a great example of that. But yes, people come to endocrinologists complaining about being tired a lot. I think people are tired. Like, it doesn't feel good.
No, it doesn't feel good. I totally agree. Somebody has a comment in here, which is just amino acids. Should we have those?
I mean, most of us get all the amino acids.
They are building blocks of protein.
They sure are. We get all the amino acids that we need. If you eat a well-rounded diet, you're getting the amino acids that you need.
Okay. I think this is a very good final question. And then we're going to just do a little, like, what does everybody need to know?
Yeah.
For someone entering perimenopause or menopause, what is one thing you wish people knew more ahead of time?
You do not have to suffer. It is unnecessary to suffer through perimenopause and menopause.
That's so great. I love that message. That's wonderful. Okay. Everybody, Gillian, tell us, when is the book out? Where can we get it other than commenting shop? And then we're going to DM you a link. Tell us more about when it's coming out and where you're going to be talking about it.
The book is coming out on June 2nd. So just a few weeks from now. You can pre-order it here and anywhere where books are sold. If you cannot get enough of Emily and I cracking each other up, then you happen to be in the tri-state area, you can see us at the JCC in Manhattan on June 2nd. I'm going to be.
Are we coordinating outfits? This is an important question. We should take it offline, but I think we might need to coordinate outfits.
Sure.
What's the best hormone? What's a good hormone color?
I don't know. I've been wearing a lot of green, but I don't know that that's a good hormone color per se. No.
Could be a good color. Okay, we're going to talk about it.
Okay.
So people, you should come. If you're in the New York tri-state area, come on June 2nd and you can see whether we've coordinated colors to discuss hormones.
West Coast, you can see me on June 11th. I'll be with Cara Natterson at Zibby's Bookshop.
Oh my gosh, that's the best. All right. Thank you, everybody. Thank you, Gillian. I love to talk to you.
Thank you,
and
Emily.
Everybody, Hormone Loop, June 2nd. Get ready.
Bye, guys.
Bye. Stop this and then